Hello everybody, Dr. K.K. Agarwal, President, Heart Care Foundation of India, and you are watching Med Talks with Dr. K.K. Yesterday we talked about male sexual dysfunction. Today we will talk about female sexual dysfunction, myth or reality. Before I introduce my speaker again, let's wash our hands. S for Seedha, U for Ulta, M for Mutti, A for Angutha, N for Nakhun, or K for Kalai. Once we have done that, let me introduce my special guest again. Dr. Deepak Jumani is back. He's a senior sexual health physician and counselor and associate professor of medicine, sexual health attached to Sir J.J. Government Group of Hospitals and Grand Medical College, Mumbai. Attached to Mumbai Police Hospital, Doctor House and Apollo Sugar Clinics as a consultant sexologist, American Board Certified Clinical Sexologist, Fellow of American College of Sexologists, Fellow of International Council of Sex Education, and Parenthood of the American University, only Indian to be appointed on the Scientific Committee of International Society for Sexual Medicine, the world's premier association of sexual health, course director of the first of its kind fellowship program in clinical sexology, started by Maharashtra University of Health Sciences, approved by the Medical Council of India, founder chairman of Indian Medical Association's initiative of sexual health, contributed several chapters and papers in various textbooks and journals of diabetology, diabetes and endocrinology on topics related to sexual dysfunction. Welcome back, Dr. Jumani. Your talk was well appreciated all across. The numbers are increasing hour by hour. And now let's listen to the sexual dysfunction in women.
Thank you very much, Dr. K.K. Agarwal, sir, for that very sexy introduction. The topic given to me today is female sexual dysfunctions. Is it a myth or reality? We all understand and know the fact that for too long, women have been culturally pressurized and indoctrinated with male-centered idea that sex must always end in an intercourse, otherwise it's not a real sex. Women who do not desire intercourse are still seen as either abnormal or suffering from some mental disorders. Women are told that sex is dirty, sin, bad, and to be done only when you get married, and only husband can or should do it. And if you do that, you are a good girl. Because of which, the reason all these things have made women in bedroom just as a spectator and not the real participants. And what is more hurting is that in this modern era, pharma industry is a curse to healthy sexuality because it's male-centered, it's phallocentric. We have got at least 1,200 brands of PDE5 inhibitors like sildenafil and all that, but very, very few drugs for female sexual dysfunctions. Because it is presumed, that women have to do what men wants, and that's not the case. Today things are changing. Even women need what men need, how men need it, even women need it. So in this next 30-40 minutes, I'm going to give you some nuggets of wisdom as to what are these dysfunctions which we are not aware of it. Women are tight-lipped, they don't say. Their silence is the biggest cry, and we as partners of them should understand, or physicians should understand all these things. I have some disclosures. I'm not responsible for Section 497 verdict, which means adultery in law is allowed. I'm not responsible for Article 497. My patient Amitabh, he said, Rekha told her that now that 497 article is off. But then he told him, now it's too late, Rekha. But then after a while he thought and he said, let me talk to Dr. Jumani. Of all the urges, the urge to have sex is the strongest urge we all humans have. Sex is God-made and restrictions are man-made. Women don't talk about it. They consider talking it as sin. They're all tight-lipped. They avoid talking about it. So it's the onus is on we physicians or as partners to talk about it. We need to break all barriers of clinical inertia and ask them, what is the problem? Do you have problems in making love? This is what we need to ask. Let me give a newer perspective. At the beginning of marriage, every wife treats her husband as God, Pati Parmeshwar. But soon after marriage, somehow, I don't know, the words change, the alphabets change. What is the difference between a woman and a man? A woman wants one man to satisfy all her needs. And a man wants every woman to satisfy that one little need of his. Every wife is a mistress for a husband. Miss for 1 hour and stress for the rest 23 hours. Friends, life has become like a penis, simple, soft, and straight. It's women who make it hard, truly. James Prescott, the developmental neuropsychologist who studied 44 cultures across the globe, his life's inference is that our brains have built-in reciprocal relationship between violence and pleasure. So if you want to decrease the violence in your life, increase the pleasures. And the power to give pleasure to each other is the greatest power we humans have. And the only difference between men and women is the desire. They tend to appreciate or think it differently. 62% of women admitted that they were not satisfied with their sex lives. How do we define a satisfying sex life? Is it enhancing intimacy and connection with one partner, cultivating mutual pleasure and reciprocity, feeling loved and desired, more focus on emotional aspects than the physical satisfactions? And some women who prefer to get treated, most prefer by behavioral or to pharmaceutical. They don't want drugs. They cite concerns about the side effects and other things. So they want something which is non-pharmacological. They want help from their sexual problems like desire, arousal, pain, orgasm, and they have a high degree of focus on emotional and relational aspects and behavioral therapies. This is what the difference between women and men is. Men always want kuch deo yaar, jaldi deo, but women want more connectedness, more emotional and relationships. So the onus of keeping the sex lives of our patients lies with we physicians. Let me give you a different perspective. For understanding female sexual dysfunctions, we must understand what is the female sexual response cycle. It begins with the desire, according to Masters and Johnson. The desire, what happens is when she is desirous, either through touch or through smell or to taste or whatever may be, there is vaginal engorgement, lubrication, arousal, breast enlarges, nipple hardens, there is muscle tension, the breathing and the heart rate becomes more, there is flushing, and the uterus also becomes bigger. And this leads to another stage called plateau. During the plateau, the sexual arousal, clitoral engorgement, vaginal clitoral engorgement, motting of the skin around there's swelling and coloration of the labia minora, which changes a little bit. There is more vaginal ballooning, and 180 degrees upturn of clitoris. It's hidden between the hoods. And then after a while, there's an orgasm, which is nothing but rhythmic contractions of your perineal muscles. And this ultimately leads to resolution, which is returning to the non-aroused state of heightened relaxations. This is a beautiful diagram to understand how different can women present with their responses. Look at the graph A. There's a smooth transition of excitement, which leads to plateau, and there are multiple lubrications, which is nothing but orgasms, and then there's a resolution. But the same woman at one given point of time can be also, look at the B now, she has excitement, but there can be no orgasm and delayed resolutions. And the third type could be, there is a brisk excitement, there may be a little orgasm, and resolution would be very early. So you can see different women having different type of pattern, or even the same woman can have different type of patterns at some given point of time. Rosenmary and Masters and Johnson changed this female cycle, also formed a different not linear, but circular type of cycle. And they said that sexual pleasure and satisfaction aren't reliant on orgasms. Orgasm is not the ultimate thing. Though orgasm may certainly be a nice bonus. That's first thing. Second thing, sexual desire doesn't always have to come before the sexual activity or arousal. Sometimes getting physical and experiencing arousal will elicit the desire to have sex. And there are certain external factors such as relationship dynamics, intimacy, and weighing rewards and cost of sexual experiences may play an important role in the sexual response cycle. The common types of sexual dysfunctions are, it could be desire difficulties, arousal difficulties, orgasmic difficulties, and sometimes when women get painful disorders. And underlying the female sexual dysfunctions could be plethora of reasons. It could be cardiometabolic disease, respiratory disease, neurological disease, rheumatic disease, and renal diseases. If you look at a low desire, which is the very common thing which we find in our class of patients, it is connected to most of the other disorders, be it orgasm or arousal disorders or pain disorders, which means what? The painful disorders can lead to low desire. Orgasmic disorder can also lead to low desire, and arousal disorder can also lead to low desire disorders. So all are interrelated amongst each other. And look at the pharma company and the research people. There are more than 34 registered studies on erectile dysfunction from our country, more than 34. But only 2 or 4 countries or 4 studies on female sexual interest or arousal desire. So 2 assumptions which guide in our field of treating female sexual dysfunctions are genital physiology, which is sufficient to define the normal sexual function and dysfunction, and subjective experience, which is the gold standard for assessment and treatment. We don't have to go be theoretical. We need to emphatically ask the patient as to how does she feel? How was her sexual experiences in the past? So we assume a woman's perception of her sexual and physiological functions are complementary sides of the same coin, and this can guide diagnosis and allow us to treat how to treat this section. And it's not sex, friends. It's the pleasure which gives them the pleasure, but it's the lover. His concern, his care gives her a lot of pleasure. And we should come out of this cultural myth that women need only penises, nothing like that. They enjoy sexual intercourse as much as we enjoy, but they think more beyond intercourse. So this is a cultural myth which we need to. And she always feels is a normal. So what? Why do we make an issue of a small tissue? That hymen. Look at the New York Times. As early as 2008, what does it rise? The hymen, the vaginal membrane that normally breaks in the first act of intercourse. What rubbish! It is not the act of intercourse which is responsible for breaking of hymen. Hymen breaks even when the girl is playing, cycling, or jumping here and there, even before her marriage. So, what a wrong thing which was being spread even by this very well-known newspaper. So, the genesis of female sexual dysfunction is men don't understand the concept of afterplay. They ejaculate and they turn themselves on other side, and this gives them a signal that he's so selfish. He's got no understanding about our regards, our feelings, etc. And usually men use women as sleeping pill. That's the fact. Let's unravel the blindfold as to how these things developed. A newly going to be married girl goes for all these issues, gets wedded, steps into the husband's home the first night. She goes then for honeymoon. The intimacies grow normally, which is normal. Then she gets pregnant and she becomes a mother. So motherhood comes in her way. And this is the point where everything changes. The body image, the cognitive distraction develops, and her erotic focus changes from her husband to taking care of the baby. Women's health issues have been challenging right from womb to tomb. Aging. We are all going to live more, with the median age at last menstruation being 51 years. Till that time today, we have seen women are fertile. Life expectancy is beyond 70 years, and large number of women are going to spend a substantial portion of their lives mostly in the post-menstrual years. That is going to be the golden life of theirs. So aging and comorbidity, physiological changes are associated with aging process. We all know they are coupled with increased evidence of prevalence of medical disorders in that age. They play a significant role in the pathogenesis of sexual dysfunctions. Hormones, testosterone and free testosterone are unchanged in women or increased maybe, but intracellular androgen decrease is a seen. There is no cellular presence of androgens, but estrogen deficiency definitely is there, which causes local symptoms that can affect and have an indirect effect on the sexual enjoyment. Let me give you a little deeper perspective. Diabetes, we all know. We've been seeing a lot of diabetic women. Huge problem. What data says, WHO reports that 55% of diabetes deaths occur in women, and it's the 9th leading cause of death in women globally. Now, amongst the Indian, the prevalence of diabetes is more in Trivandrum in India. So please understand this. And what are the implications? When there is gestational diabetes, the partner, the patient is at a risk of getting permanent diabetes, and even their children are going to get diabetes. 30% of women who develop gestational diabetes had a maternal history of diabetes, and they will continue to be diabetes, and maybe their children may become diabetes. So what is it? In gestational diabetes, there is a risk of miscarriage and stillbirth. So she got pregnant in spite of the fact that she was diabetic. So there is a risk of premature death. There's a risk of birth defects. There's a risk of excessive fetal growth, complications like preeclampsia, hypoglycemia for the baby, future risk of diabetes, and also due to transgenerational transmission. So all these things occur in a diabetic woman after she has sex or gets pregnant. So if this is true, so if a woman has gestational diabetes, should she not have sex? Is this what we need to understand? No, that's not the case. So why women want to have sex? They want to have sex as they have a desire. They also have pleasure of intimacy. They also want to have children. They are expected to have sex. They are forced to have sex by dominant husbands. They are paid to have sex. And these are the reasons. Now let's understand what actually happens during every phase of the female sexual response. During sexual dysfunctions can occur at every stage. It can occur at desire, it can occur at arousal, it can occur at orgasmic stage, or there are painful conditions. DSM-5 criteria of diagnosing female sexual dysfunctions are as follows. The female low desire and arousal disorders have been clubbed to female sexual interest arousal disorder. So that's the first disorder, which means she has no desire or she cannot get aroused. Female orgasmic disorders have remained unchanged as they were in DSM-4. And the last one, the painful one, the dyspareunia and vaginismus, they are all merged into the third type of female sexual dysfunction, which is nothing but genitopelvic pain or penetration disorder. So there are three disorders which we need to understand in women sexual dysfunction. Now, what are the reasons for it? There are certain things which get inhibited in them and certain things which get excited. So we need to understand this tipping model. Now, the things which turn them on are certain hormones and certain neurotransmitters. They are dopamine, norepinephrine, melanocortin, oxytocin, estrogen, and testosterone. These are excitatory, or they make her hot or horny. That's what we call it. And the things which turn them off or inhibitory are serotonin, prolactin, opioids, progesterone. They inhibit. So there has to be a balance between these hormones and neurotransmitters. Along with this, there has to be physiological and organic issues, psychosocial, cultural and behavioral issues in both the things. Whether they are inhibited or excited, they can all, again, this is a beautiful model to understand that it's a holistic thing. Both the things we need to take it into consideration to treat female sexual dysfunctions. Now, what happens in desire? Sexual desire includes physiological, cognitive, behavioral components, which is manifested by sexual thoughts and fantasies, interest in participation in sexual activity, initiation of the sexual activity, and receptivity of the partner approach. So these things are very important, because if we have to diagnose that she has a desire disorders, These are the questions we ask. Do you get sexual thoughts or do you get fantasies? Do you initiate the sex? Are you receptive to your partner when he asks for sex? So these are the questions which give us a clue to diagnose the desire disorders in women. And arousal is a phase where sexual excitement is manifested by congestion in the pelvic area, lubrication in the vagina, and there's a swelling of the external genital. And this is because of estrogen and vasoactive intestinal peptide, which is mediated through autonomic effects, the pelvic blood flow. Certain neurotransmitters also come into play. Low desire, please understand, it is increased activation of prefrontal cortex, which increases the inhibition and there is no desire left. Now, there are so many conditions which potentiate the sexual desire which gets impacted. Amongst them, depression and anxiety is the most common. And there are a lot of male factors which are responsible. A male having low desire, having erectile dysfunction, having premature or delayed ejaculation will also give rise to low desire in her partner. And there are so many medical conditions. Amongst them, depression is the most common thing which can give rise to low desire. You have hypertension, thyroid, pituitary tumors, urinary incompetence, spinal cord injury, arthritis, dermatological conditions, so many gynecological conditions, malignancy. But depression is the main thing which we see. There are certain hormonal factors which can also cause. It has been seen that in these patients, when you give them testosterone, it does improve their performance, their desire also. There have been beautiful studies to say that circulating androgen levels have been very important in women who have got good desire. And so this is important to understand that androgen supplementation in women can help increase their desire. Now let's come to the third part, the orgasms. Now what is orgasms? It's a process of physiological release of sexual tension associated with the rhythmic contraction of the perineal and reproductive organ structures with cardiovascular and respiratory changes. When she is orgasmic, there is increase in heart rate, respiratory rate, and blood pressure. All three increase. It's a feeling. It's not a physicality. It's in the mind, not in the clitoris or in the labia or in the vagina. It's a gateway. The gateway to it's through the clitoris, because clitoris has got bunch of neurological tissues, nerve tissues, and nerve endings. More than 8,000 nerve endings are there in the clitoris. One can feel orgasmic even when she is not having intercourse. The mechanism is through estrogen, oxytocin. There are so many other neurotransmitters which are involved. There are many men who say, my wife does not feel orgasmic at all. It's a very well-known, it's a very understood clinical setting which we see in our patients. And the reasons are, there have been a lot of relationship issues. This partner has been abused, certain chronic diseases like multiple sclerosis, cardiovascular disease, even hypertension, even peripheral vascular disease, smokers, smoking women, diabetics, some women having urinary incontinence, or some women who are on psychotropic medications like antidepressants, antipsychotics, or mood stabilizers, and some who have got pelvic disorders, post-surgery, they have got radiations done, or certain traumatic conditions. These are the pictures which show how the vulva extends, the clitoris goes beyond the hood, etc. What happens in diabetics? Besides all these things, there are certain additional things which happen in the sexual functions of women who are having diabetes. Our clinical study at KM proved that in women we found they had either less or absent desire, less or absent lubrication, less or absent orgasms, painful sex, vulvovaginitis, candidial infections, and depression which was seen in. A lot of studies have been proven that when they have, it all depends upon how long the diabetes has been there, the durations, and we see every domain of sexual functions getting evolved in patients who are diabetic. Even in the women, there have been reduced orgasm, reduced lubrication, and they have painful intercourses. This is what we see in diabetic patients. When you give insulin to these patients, they suffer more. Then they avoid having sex. So it's been proven that insulin-treated women have a lot of other issues. So it's a benign neglect. A lot of studies have proven beyond doubt, meta-analysis, a lot of multi-centric trials have been done, and it is proven that female sexual dysfunctions in diabetes occur at every phase of sexual response. There are a lot of correlates of sexual problems associated with distress and many other diseases, including arthritis, hypertension, asthma. But in diabetes, you find at every level there is a distress, desire level, arousal level, and orgasmic levels. So how do we manage female sexual dysfunctions? We need to assess by a very beautiful model called Implicit model. Then we have cognitive behavioral therapy, sex therapy, mindfulness. We need to control the metabolic syndrome as we did in patients who had erectile dysfunction. And of course, we need to take care of depression in them. What is Implicit model? It's a very good model to manage female sexual dysfunctions. The P of Implicit is permission. We need to ask the patients, we need to obtain permission from the patient to discuss sexuality. You can say that I ask all my patients about their sexuality. Is that okay to do with you now? Then the second is LI, which is limited information. Please tell your patient that, give them some information about it. Inform the patient of what is normal sexual desire, what is normal orgasm. Then the third is SS, which is giving specific suggestion about the patient's particular problem. Tell them that there are patients with diabetes who have got these issues, but today we have so many good treatments available and these issues can be resolved. So this is specific suggestion. And the last IT is intensive therapy, which we can give, or we can holistically, we can take the help of a psychiatrist, endocrinologist, dermatologist, physician, and ourselves. We can completely give them a good treatment for this. There are two beautiful validated questionnaires, FSI, FI, and BDI, which we use in our day-to-day practice in treating females. So how do we manage? We need to understand what are the situations that she in. We need to understand a lot of other psychological factors like body image, self-esteem, is she been abused, and a lot of health-related factors like her mental health or physical health, what medications she is on. And the psychotherapy forms the mainstay of it. Masters and Johnson sex therapy, mindfulness, CBT, and couples therapy. In mindfulness, this is a beautiful model, where sensate focus, which is non-sexual touching, solo body exploration, genital touching with partner, outer course, and then in the end we teach them intercourse. So this is what it is. And during sex, mindfulness, what happens is there is increased attention, increased awareness, and they are being present in. There is decreased distraction, decreased anxiety, increased relaxation, increased connectivity, and there is less self-judgment in it. So this is what. There's a beautiful program called Pursuing Pleasure program available on the net. It's a CBT program. Anybody can download and run through it. It's nothing but psychoeducation. There are communication exercises, including sensate focus. Fortnightly in chat groups, they all discuss all these things. Cognitive behavioral therapy, we all are aware of it. We try to change the maladaptive thoughts and repetitive thoughts, change unreasonable expectations, and discuss normal and values about sex, and focus on the misinformation about sexuality. Because we know that changes in the thoughts, attitude, and behavior lead not only to changed feelings, but may also affect sexual physiology. And changes which happen in the sexual physiology lead not only to change feelings, but may also affect thoughts, attitudes, and behavior. And this is how CBT plays a very good role. Couple therapy is the most important thing. We need to focus on the dynamics of the couple as to what the male needs and what the female needs are. We need to increase their communication. We need to stop giving pressures to each other, restore their affections for each other physically, and increase the emotional intimacy by making them aware as to how important the partner is. And this brings trust and respect between both of them. The pharmacological treatments are, we can give them estrogens, testosterone, tibolone has been tried, PDE5 inhibitors along with other vasodilators. The newer drug is flibanserin. Botox we give in painful conditions like vaginismus, etc. There are a lot of herbal agents, lubricants, water-based lubricants are available. Bupropion is a drug of choice for depression in every diabetic woman. O-shot now is being practiced by many gynecologists. They inject platelet-rich plasma at specific sites in the vaginal wall or in the clitoris or in the labia, because they understand that it is useful in treating orgasmic disorders, arousal disorders, and hypoactive sexual disorders. But we have no robust data on this, so it's still a question mark. What we need to understand, we need to control the metabolic syndrome. If at all she is hypertensive, If diuretics have to be given, give indapamide. If beta blockers have to be given, prefer nebivolol. Otherwise, ORBs are the best. Testosterone, along with estrogen, has been very good in postmenopausal women. Increase in the sexual thoughts, fantasy, decrease in pain has been seen. Tibolone, a wonderful, just a small dose of 2.5 milligrams for 3 months. It increases sexual fantasy, arousal, desire, etc. PD5 inhibitors like Viagra have been tried and has been shown beautiful results, but we do not have enough data to prove, because PD5 inhibitors anyway have to increase the pelvic blood flow. So it does. Sildenafil is very good in women who are treated with antidepressants and have got sexual dysfunctions. Botox in pain has been tried. Flibanserin, a newer drug which is come in the market, very expensive, is available today for the desire. But this novel drug is just like a placebo. It doesn't work. What we in India give is DHEA tablets, and we give them estrogen creams. We also give them testosterone patch. We also give them PD5 inhibitors. There are other strategies which they combine testosterone with this and testosterone with PD5 inhibitors, and they see that these patients get. And about the pain, we need to break that pain cycle. With a lot of medications are available, but the best for painful conditions in female sexual dysfunction is low-level laser therapy, which is studied and patients have got beautiful results with. We need to understand that there are certain changes which are going to happen. We need little longer foreplay. We need to understand about and also involve ourselves in the alternate forms of intimacy which is there. You can use water-based lubricants or estrogen gels or patches for vaginal dryness, which is very common. Bupropion has been used for depression in sex. So there are 4 things which we need to understand. These are the signals. If your patient, if the female has normal or high drive and is motivated, we need to check the distress and the contextual factors. This is normal desire and normal motivations. If she has low desire but highly motivated, you assess her hormonal profile, assess the androgens and prolactin. Her prolactin may be high. So this is called libidinal dysfunction. And if the desire is high and normal, but the motivation is low, then there is some problem amongst each other. So assess the quality of intimacy and relation. So this is due to sexual dissatisfaction, the sexual dysfunctions. And if there is no desire, no motivation, assess for depression, biological and other relationship effects. You need to optimize female sexual dysfunctions by giving optimum pharmacological therapy, sex therapy, relational therapy, remove the risk factors, and of course CBT. There are newer drugs which are available as combination of sildenafil and testosterone, buciprone and testosterone, bremelanotide. Beautiful results have been seen with this, and D-cycloserine, which is there. Oxytocin in the form of nasal spray increases the bond between both of them. That's fine. But what is more important? Why these sexual dysfunctions occur in younger people who do not have any? That is because they all ignore them. Women always felt ignored by their partners. They felt minimized. They never got supported. And what happens to the male? He feels ignored. He feels criticized. He feels corrected all the time. And if this happens, both of them, husband and wife, create a wall between each other. Even if you dismantle one brick, you'll see a shining light. And with the help of communication and appreciating each other, you can bring down or dismantle this wall and have beautiful relationship again. A very important factor in women we have seen is body image. They're very much concerned about their body image. Now, body image involves their perception, imagination, emotions, and physical sensations about their bodies. It's not static, it's ever changing, and they're very sensitive. It changes their mood, etc. In today's society also, sexuality is closely linked with the body image and self-esteem. Women are brought to understand and feel that they deserve sexual pleasure only if they look a certain way or the weigh a certain amount. This myth needs to be busted, because we need to understand that we need to think yourself as a sex subject rather than as a sex object. Everyone is a sex subject. This myth needs to be gone. Diabetic women who don't get enough affectionate physically, they suffer from depression. And every diabetic have this issue properly. For conjugal life, constant connect is a must. There are a lot of alternate ways besides coitus which we can do. So my take-home message is what men should do to increase intimacy. Always agree with her. When she comes back from work or when you come back from work, listen to her. Don't try and tell her, "Arey, you should have called me. You are a big banana if you tell." It's all done. She wants to vent it out. So listen to her. And whenever she's speaking, smile and keep your mouth shut. Just listen. Give her trust and time, not gifts. Encourage her to discover her hidden talents. She's a very talented person. Share and be transparent. Look at her inner beauty. After play, I've explained it needs to be done. Women should avoid smoking. Smoking is disastrous for them. Make your stomach not a waste paper basket. Kam khao, gum khao, nam jao. Beautifully said, and it's a Jainism which proves this. You need to understand your stomach, your body is a temple, your stomach is not a waste paper basket. Do little workouts to keep yourself fit. Love each other unconditionally because you're partners for life. Increase the romance. There is no GST on romance. Romantic periods are beautiful, they are memorable. Imagine when you were romantic, how good the time passed and how beautiful it was. You waited for hours together for it. All couples needs vitamin touch, which is vitamin T. It promotes good health and intimacy. It's essential for well-being. It soothes aching muscle, reduces stress, strengthens immune system, unblocks repressed emotions, sense of trust, and also increases sexual energy. Trust me, friend, this is true. Sensual massage is the best. Hugging is very good. Bring in harmony. Don't harmony. In Hindi, it is called when your partner says something. Harmano. That is harmony. Nothing. Don't have to give back to her. Don't have to show your dominance to your wife or to your partner. Harmano. That is harmony. That is better. There is a gender bias. Women are not given enough hormones, so they feel invisible. A woman without sexual hormone is like a Ferrari without fuel. She's a Ferrari, but she does not have a fuel. So what's the point? Thrill her body with giving hormones. Pulse therapy is advisable. Nothing wrong. More important today, we are seeing the sex industry is booming. Mapping of porn industry is too much. Medical aesthetic industry is the vaginal rejuvenation. It's a multi-billion-dollar industries. Women are going in for rejuvenating their vagina, mammoplexy, reducing the butt size, thigh size, so many things they are doing, facelifting and all. But please remember, you are a sexual human being. Accept yourself the way you are. We have seen everybody same below the umbilicus. There is nothing different in any woman. So you are a good sexual human being. You are a normal sexual being. Accept this fact. These women were all abandoned by their husbands, and they were advised to do makeovers. And when they did makeovers, again they were admired by their husbands. So my advice to all women listening here is: spend your husband's money, go to the parlor, try and look as beautiful as possible. Spend their money, do any makeover and try and look slimmer, look beautiful. Nothing wrong in that. It's always good. They will be attracted towards you. Sada sexy raho is my message to all the women here. So the key to having good sexual functions in women is, must understand the origin of a child is a mother, a woman. She shows a man what sharing, caring and loving is all about. That is an essence of a woman. You must give importance to every woman in your life, not even even your partner too. A woman is the best masterpiece of God, needs to be admired, adored and respected. Look at Mahabharata, look at Ramayana, learn from the epics, what happened, how disastrous the whole thing went on. But we know men will be men, they will never improve. Sexual dysfunction is not an option, not for anyone. But it is how gracefully we handle the process and how lucky we are as the process handles us. The fact is, female sexual dysfunction is very prevalent, is highly prevalent. In diabetics, it is more than 40%. Indian women are tight-lipped. Phallocentric culture is a roadblock. They can't decide what to do. They don't want oral sex, but the husband wants oral sex. They want oral sex, but the husband doesn't. So this is a roadblock. The sex industry is blooming and exploiting. Sex is the creative impulse of the universe. We are all born out of it. It's God's greatest gift to mankind. To make it a gift, two individuals must make themselves vulnerable to each other. Why only men? Why only men should desire and demand? It's the women also who need variety, who also needs the same thing. The language of love which a woman understands is communication and romance. If you have these two in your life, friends, you will have no issues at all. Try and cultivate your own garden. This is what Voltaire said. Your partner is like a garden. And if you are monogamous, your partner is your garden. Otherwise, if you are into polygamous relationship, the other people are just like jungle. It is a choice which you have, whether you want to be a gardener or a jungle. But if you want to be a gardener, you need to work, you need to devote time, you need to cut the right type of grass, put water, etc. And so Voltaire beautifully said, for a good married life, for a good sexual life, try and cultivate your own garden. Be monogamous. This is my book, Sex Has No Expiry Date, available on Amazon. So friends, female sexual dysfunction is highly prevalent and undertreated problem in India. By addressing the physical, psychological, and couple factors, physicians can play a major role in helping their female patients enjoy improved sexual functions and increased self-esteem. It's the sensitivity of the physician in approaching the problem which is very important. Men should learn to understand the silent cry of their partners. Men's rational approach and accepting feminism with adoration along with the relevant treatment to these women will go a long way in improving their sex-starved lives. Friends, height, weight, age, color are nothing. It's just numbers and names. Aging, we are all going to age. But according to me, if we live rightly, our biological age is 130 years. So even if you are 70, you've not even reached adolescence, you've not even reached adulthood. So please understand, you can live up to 130 years. That's your biological life. There are so many plant species which are living. So there is a mechanism, in a narrative in the universe which is available. The hydrops and the so many other things, they live for more than 100, 120, 130 years. So there is a mechanism in nature where we also can live 130 years, nothing wrong. We have some cities across the world where people are living, learn from them and have a good quality of sex life, which is very important. Friends, if you do understand all these things, really sex has no expiry date. So female sexual dysfunction is a fact, not a myth. This is existing, but we need to be proactive. We need to ask our partners. We need to go take them to physicians and get the things resolved. Assess them properly. Thank you very much for all your love.
Thank you, Dr. Deepak, for a beautiful illustration and presentation on female sexual health. Best lubricant after menopause.
There are a lot of water-based lubricants available. Sometimes they are not available with the local chemist, but in the gray market, there are a lot of things available. There are some companies which have come out with it. KY jelly is very good, which you can use and very, very effective, safe, harmless. But before using all these things, find out the reason for the dryness. Is she on any antihistaminics? Is she on any hormones? Is she on any antipsychotic drugs? So try and rule out all those causes before using these water-based lubricants.
Pre and post-COVID experience in female sexual dysfunction. Is there a change during the COVID time?
Yes, there is a change. The sale of IPIL has increased. The sale of condoms have increased. So there is increased physical activity, sexual activity, which we have seen in our patients. But some patients who were working during COVID, long hours from home, etc., they also developed erectile dysfunctions. So this is what we have, and they developed erectile dysfunctions. They couldn't go to meet their doctors. They couldn't do online consultations because of the stigma or whatever they say. They don't want to become judgmental. They didn't take treatment, and so their partners lived a sex-starved life. So we had seen a lot of different things in this COVID times.
What about metabolic syndrome? We have been talking about diabetes, but I'm talking about pre-diabetic status, which is metabolic syndrome and insulin resistance. You said in diabetics, 40% of the women have sexual dysfunction, but 5 years before the diabetes, you have metabolic dysfunction, cardiometabolic disorder. What do you think that the disease starts?
Yesterday also I said that if you have a patient who's 30 years old, and if he has a family history of anything in metabolic syndrome, assume that he has a metabolic syndrome and try and spend some time with him and counsel him for how to reverse the metabolic syndrome or retard the onset of it. So this is what is very important. When you diagnose diabetes in our patients, he's already started having diabetes 5 to 6 years back. We all know about it. So this is what we need to tell our patients. We need to counsel our patients as early as 30 years in those patients who have got family history of metabolic syndrome. Because we can ask the family history कि भाई आपके किसी को ये है क्या आपके घर में, and then we can manage these metabolic syndrome with less severity and control them. If he's a smoker, counsel them. If she's an alcoholic, counsel her and try and make her understand the importance of lifestyle modification with counseling and behavioral therapies. You can definitely increase their good quality of sex life.
Obese women, a sexual life of a woman or a female who is very obese.
Yeah. So this is actually a turn off for men many a times, but all obese women become less desirous because of the gestures or because of the body language of their partners. This is what I have seen. Many obese women come to me, वो तो मेरी तरफ देखते ही नहीं है. I say, I don't think I'm so attractive enough. So they try to become guilty about their physique. Of course, advise them on reducing weight, how to reduce that, tell them how to do exercises, what she should eat, what she should not eat, all that. But even obese women, by changing a different position, making them sleep on the edge of a bed, and the man can stand and face her and have intercourse. By changing positions, they can have good intercourses. And I've seen obese women getting pregnant even with their obese husbands. It's not impossible. Yes, we need to tell them to change different positions rather than changing partners. So that is important. And of course, counsel them to reduce the weight. Bariatric surgery is available today. It's proven that they do reduce 50, 60 kilos if they are moribund obese. Nothing wrong in that. They can go for it and have a good quality of life.
PCOD girl getting married and the recent married life with a PCOD girl.
Yeah. See, PCOD girls, if they are symptomatic, they already are on metformin. Okay. And they also need the similar type of advices of reducing weight, etc. And metformin today is known to improve the endothelial functions. So in fact, they have more desire to have sex. It is not that women who have PCOD, they do not have desire. Yes, fertility issues may be there with the ovarian functions getting haywire, but the desire is always there. So we can correct that ovarian functions and make them fertile, and they can also have good quality of sex life.
Sexual life after hysterectomy.
Nothing wrong. What does a uterus has got to do when you are having intercourse? The vagina is enough. Nothing wrong.
Sexual activity.
If they have oophorectomy done, their estrogen levels are less. So they need little bit boost in the form of desire. They can take estrogen ointments. They can take testosterone gels. They can take DHEA tablets. They can take tibolone, a lot of things to give them to increase their desire. But what is important is the connect has to be there. There has to be, they should feel wanted. And if that is shown, there is absolutely no problem in having intercourse, even with she's having hysterectomy. Nobody knows. Nobody can even, feel it while having sex, whether she has a uterus or no, it's not felt also.
Post-menopausal sexual life. Post-menopausal sexual life.
That's a beautiful life to have sex post-menopausal, because majority of the women spend more of life in the post-menopausal period where they have no risks of pregnancy, no risk of menses, no risk of any complications. So they can experiment and experience all different poses, all different positions, and have good enough sex with an excited partner. All they need is a good communications and good affections and good wanting for each other.
Depression and sexual life.
Depression definitely affects the sexual life. If they are on antidepressant, it worsens it. They need counseling. They need some lighter medications. Especially women need bupropion, which is fantastic. Within 15 to 20 days, we find them losing the thoughts of being helpless, hopeless, feeling sad, crying, etc. So we need to, and also motivate them to increase the physical activity, get involved into certain good things, and increase intercourses, also increase the frequencies of orgasms in them, so they become good. Depressions and sexual functions are possible.
Anxiety and sexual dysfunction, anxiety and sexual life.
Anxiety is there in women whose husbands have undergone bypass surgery or having some issues, or they are frail, इनको कुछ हो जाएगा तो, and all that. So they all need counseling. I don't think for anxiety we need to give them drug, because I feel that anxiety is nothing but a distance between reality and expectations. So if I'm anxious of getting banged my car, should I stop driving? No, it can happen. If I'm sitting here, the roof can fall. So should I not sit here? So my anxiety can be treated with counseling and repeated CBT sessions. These anxieties can be off, and they can have good enough sex under the care of physicians. If their husbands have some risk of cardiovascular disease or any other disease, they can definitely have good enough sex.
Breastfeeding lady and sexual life.
That's a little tricky, breastfeeding. When she's breastfeeding, her erotic focus is not towards her husband, but her focus is mainly on feeding the child and seeing that the child becomes healthy. So at that time, the husband has to understand and do something other than this, other than having, the normal thing what they do when they are doing foreplays. So, but sex is possible, nothing wrong. They can have sex. If she is not bleeding, if she's comfortable, if she's undergone hysterectomy, if the stitches are healed and she's doing her exercises, and if the child is sleeping, and if both of feel that they can have sex, they can have sex. Nothing wrong in that.
Why honeymoon was started? When and why honeymoon was started in Indian Vedic literature?
That is to make them come closer immediately, because sex is the best connect between two human beings. There cannot be anything better than that, and they have to live the life with each other. So this is the best understanding physically when they come closer to each other, and that is why the honeymoon was started.
So I want to end by saying what Deepak Jumani ji has said, that everybody have 5 needs: physical needs, mental needs, intellectual needs, egoistic needs, and you have spiritual needs. अगर आपको पांचों अपने हस्बैंड वाइफ को मिलती हैं, then you say this is called made for each other. नहीं तो क्या होगा, फिजिकल नीड्स आप पति पत्नी के बीच में है, मेंटल नीड्स के लिए आप कहते हो मेरी बेस्ट फ्रेंड वो है, इंटेलेक्चुअल नीड्स के लिए आप बोलते हो मेरा देवर है, मेरे कलीग्स हैं, मेरा बॉस है जिससे मेरी इंटेलेक्चुअल नीड्स हैं, इगोइस्टिक नीड्स के लिए बोलते हो मेरा ससुर मेरी सुनता है, या फिर मेरा बॉस मेरे को आगे बढ़ाता है। स्पिरिचुअल नीड्स के लिए आप बोलते हो मेरे गुरु हैं, मेरे उनसे मेरी स्पिरिचुअल नीड्स मिलती हैं उसके साथ में। सो पांचों नीड्स जरूरी हैं, और वन ऑफ द डिस्प्यूट रीजन में बी between husband and wife may be that you don't end up in getting all the 5 needs between each other. So thank you, Deepak ji, to be here. This was our part 2. We will have one more part 3. So that's all for today. Namaskar and thank you.
Namaskar, sir. Thank you.